Okay, well, good afternoon, everyone, and thanks for joining us as part of our latest Circle seminar where Dr Karla Zimpel-Leal will be talking about her work on the value propositions of emergent home care models in England, implications for care workforce. Dr Karla Zimpel-Leal was a UKRI Innovation Fellow as part of our Sustainable Care team and still maintains close ties with the programme as a visiting fellow. My name is Matt Bennett and I'm based at Circle and I'll be chairing today's session. I'm going to introduce Karla and then she'll talk for about 30 to 45 minutes. I'm delighted to be able to introduce Dr Zimpel-Leal. Karla is a senior lecturer in innovation and enterprise at Oxford Brookes Business School and is a visiting fellow within the Sustainable Care programme at the University of Sheffield. Her research is inspired by real-world challenges that can inform both academia and industry, and it is aligned to the UK's industrial strategy grand challenge of an ageing society. She is examining emergent and disruptive home care business models for older adults, investigating how these organisations create, develop and capture value and how they are shaping the care landscape in England. She is also looking at the professionalisation of the care workforce from skills and development to creating a workforce strategy. She works closely with home care providers, policymakers, regulators and commissioners in the care sector, advancing business model innovation, promoting sustainability and growth, as well as influencing social policy. So, without further ado, it's my pleasure to introduce to you all Dr. Karla Zimpel-Leal. Karla, if you're ready, the virtual floor is yours.
Yes, thank you very much, Matt, for the introduction. And it's absolutely a great pleasure to be here. So oh, excellent. Share my slides. So what I'd like today to do is just to share some of the findings from my fellowship, as Matt mentioned, which was around emerging models for home care in England, and also some of the implications for the workforce. So first, I'd just like to acknowledge that this is funded by the ESRC fellowship between January 18 and March this year. And there is a related publication to this presentation, which is obviously a lot more in depth from what I'm saying, and that will be available from September, I guess, from Advances in Healthcare Management journal. So just a quick look at the agenda. So I'll talk a little bit about some background on home care market and the workforce, then the methodology of the fellowship, and then the emerging models and market and workforce implications, and then the conclusions. So just a bit of background on the fellowship. This was a UKRI Innovation Fellowship and is related to the grand challenge of an aging society, which was based by the industrial strategy that set out the grand challenges for the UK, which were artificial intelligence and data, clean growth, future of mobility, and an aging society. So this particular challenge came from the fact that the UK and obviously worldwide, we have a population that is aging, and this prospect of longer lives will require people to plan their careers, their retirement differently, and create new demands for technologies, products, services, including new care technologies, new housing models, and also innovative home care models. So the fellowship was entitled Advancing Business Innovation and Skills Development in the Home Care Sector. And some of the objectives were to examine how these models are similar or different from a time and task model, which prevails in the home care, and then to produce a good understanding of the business models of these providers, and they were quality-oriented home care providers, and also to understand the implications for the care market and workforce development. So the home care market, just a brief overview. The home care can broadly be divided into two segments. So we have the commercial home care, which includes provision by local authorities, the National Health Service, private and voluntary sectors. And we also have the informal home care market, which tends to be unpaid and is that care provided by family, neighbors, friends, relatives. In terms of funding, historically the home care market has been quite highly fragmented from the supply side. And adult social care in England, unlike healthcare, is not free at the point of use. So is both needs and means tested. And so the state reserves that right to provide care, usually for the ones with the highest level of need and the lowest means. And then we have a large self-funding market, which is obviously privately commissioned. Because we have this needs and means tested, a lot of people are not eligible to this publicly funded care. So it's considered, I think, it's estimated about 1.4 million people in England are not receiving the care they need. In terms of regulation, we have the CQC, the Care Quality Commission, that regulates the health and social care in the UK as a whole. And then we have, particularly for the home care, the UK Home Care Association, which regulates those providers, although is non-compulsory to be a member of the UK Home Care Association, but is usually perceived as good providers are normally members of them. And the care workers themselves are unregulated at the moment, so there is no body that regulates them. So how is the home care landscape? So we have a few trends going on. So 9 out of 10 people want to live independently at home. There are around 875,000 people that receive state-funded home care, and about 360,000 people that self-fund their own home care. In terms of the market value, is around £85 billion, 66.4 billion in informal care. So there's around 8 million people that provide unpaid care for home for loved ones, and 18.6 billion pounds the value for commercial home care. In terms of the number of organizations, there are around 10,000 registered home care organizations and an estimated 3,000 unregistered. So some of the trends and challenges in the home care market, we have some trends. The ability to win local authority business is declining. As providers struggle to survive, is a very high cost, low profit kind of market. Larger providers are moving their business to privately funded market that is perceived as more buoyant with higher fees. And these smaller, more niche home care providers are emerging, and they are providing more sustainable value propositions, mostly for the self-funded market or a combination of direct payments and self-funding. And there is this shift away from institutionalization. And some of the challenges that the market is facing are around local authorities that are very risk averse, and they have very rigid commissioning and regulation. And we have a huge problem with the decommission of existing models, which is directly related to the lack of transformation funding. So if we're going to move away from this, from the time and task, for example, we would need some kind of funding to facilitate that transformation, because likely they would be running parallel until new models emerge and become more prevalent. And the rationing of care, so not everyone's needs are met. As I mentioned, about 1.4 million are not receiving the care that they need. So just a summary of what I just said. So people want to live well and independent at home, increasing number of working age and older adults with multiple complex needs, council not supporting people with low and moderate needs. There is a shift away from residential care. The private home care market is growing rapidly, and new models are emerging. And on a good note, over 82% of home care providers are rated as good or outstanding, but a higher proportion of those are on the privately paid market. So what about the workforce? So the workforce is a quite considerable, chunk of in the UK. So we have about 1.6 million jobs, and for the first time ever, we have the same amount of jobs in home care that we do in residential care. So for you to have an idea, so back in 2012, there was about 425,000 jobs in home care, and now we have 685,000, which is the same as residential care. And it's estimated another 900,000 jobs will be needed by 2035. The staff turnover is around 40%, and the staff vacancy rate in home care is about 2 times higher than residential care. But the terms and conditions for employment are quite poor. So they have national minimum wage, 0 hours contract. The workload and the work environment is quite challenging. The average age of a care worker is 43 years old, although that number is rising every year. And the majorities are female, so 84% women, 16% men. In terms of nationality, around 83% are British, 7% European, 9% non-European. Mind you, these are data from 2019. I don't know what's going to happen now or how does that change. Obviously, that ratio is very different in London. So in London, the British ratio is a lot lower. But that's a national kind of average. So some of the, just an example here in terms of the pay in social care compared to the NHS. So the social care here represented in red or pink, and the NHS in blue. So a care worker working for social care earns 21% less than a care worker working in the NHS. And the same for a nurse in social care is a lot less, the pay, than the NHS. So there's a huge problems in all sorts of areas, but pay is definitely one of them. So what are the challenges currently faced by the workforce? So we have challenges around recruiting and retaining good quality staff. So there's a huge problem in terms of the number of jobs and also the quality of jobs. Also, as I mentioned, the care workforce is getting older. There is a lack of career pathways and fair wages, and the experience or clinical skills are not acknowledged. Living wage is very low. There's a lack of job security. So many of them are casual workers, which might work for some, as we're going to see in a minute, some of the emerging models, but not ideal for the majority. They also have problems with schedule of work, can be scattered and not worthwhile because they have all the traveling involved, etc. And the funding, employers claim that funding doesn't allow them to do more for their staff. And then they also lack industry bargaining, so they don't have this collective bargaining to protect both the economic and non-economic interest. So the workers, they don't have any constructive programs to support them, which leads to poor social and economic well-being. And obviously the recognition is a huge problem, which a lot of us thought it would change with the pandemic, and it might have done for a little while, and then everything kind of seems to have gone back to normal, or how it was before, not normal. So just a very brief overview on the methodology used for the fellowship. So it was a literature review of academic and grey literatures, and the main method was semi-ethnographic methods directly with the home care providers. So I worked directly with UK Home Care Association and Care England to understand the market and also to recruit these quality-oriented home care providers. And there were 5 of them with 33 interviews and 4 short-term placements. Unfortunately, the last one I couldn't do because it was in the beginning of the pandemic. And followed by observations and a drawing of their business model canvas. And it was much more of an action research approach with discussions, workshops, and knowledge transfer with among them and between me and them. So the business model canvas, if you're not familiar with, this is kind of the initial tool that I use to talk to these home care providers. And they included things like the partners they use, the activities, their value proposition, the customer relationships, customer segments, their cost structure, and the revenue streams. And that's a pretty useful tool because it's very well known both in academic terms and also, you know, when you talk with business owners, they have a pretty good idea of all these things. So it's very easy to start a conversation. And then my observations with the workforce as well. Then I looked for different parts of the canvas. So the time and task model that we are comparing these emerging models to. So the majority of care commissioned by local authorities in England is the time and task based. But the value proposition of this model is efficiency focused. So as I said, the home care is commissioned, I think that's 152 local authorities using this model. And services are delivered through care packages in short time slots, and they focus on completing normally personal tasks. Some local authorities have their own in-house services, but the majority of home care provided is by independent agencies, and they included for-profit, not-for-profit, third sector organizations. They tend to offer kind of inflexible services. So this approach can, for example, leave little time for home care workers to talk to service users or to help them with any additional activities they might want or they might mention during a visit. So it's kind of inflexible. They have to prioritize procedures and not outcomes. And the workforce works in a strict accountability. So the burden is quite significant by this model. For example, they have dressing the client 8 minutes, so they have a list of things they have to do with a certain allotted time. But as we know, real people don't live in tick boxes, so they might need different things on different days. And because they have to follow this strict accountability, often it's not possible to incorporate those changes. So what are these emerging models? Sorry, it's a big slide. I was going to show a bit of the time, but for some reason Blackboard didn't like it, so I'm just giving it the whole lot at once. So there's a huge range of home care models that we looked at. I probably won't go through each one of them, but so we have things like social enterprises, micro enterprises, which is really things like community catalysts, patch-based model, cooperatives, living care, integrated health and care, still going on after many years, decades. And we have very niche providers, elite providers, platform model, enablement program, community-based, social prescribing, preventative models, all sorts, as you can see there. So the ones that I will be talking more about the value proposition are the platform or uberisation model, the living care, the preventative or tech-enabled home care, and self-managed care teams. So I can go through them all if you like later on, but I'm just conscious of time as well. Okay, so the time and task model, as I mentioned, is very much a command and control type of model, very much dependent on the system. And all these new kind of emerging models over the last decade or so, I find that the dependency is much more on collaboration with partners or participation with the workers or with their employees or with the people the clients and so on. So the time and task, it's the majority provided by local authorities is time and task. As I said, they have this standardized care packages. They're regulated and efficiency focused. So then we have the uberisation model, which is more of a disruptive service that allow the care recipients and the care workers to connect directly with each other. And it also attracts kind of new entrants to the market in the form of care workers that are kind of tired of working with time and task, and that are also looking for more work flexibility, and also care users that are looking for a more personalized service and choice. They have a self-employed workforce, and they tend to be unregulated because they don't directly hire their workforce. And then we have living care, which is a more intensive care normally. The care worker would live on site for, it's usually 2 weeks on, 2 weeks off, or something like that. So there are usually a couple of care workers that would stay there for 24/7. So a very different model, but it's becoming more popular. And they have a huge focus on recruitment and training. So the recruitment process is quite long, and then the training as well is quite intensive for a few weeks. And that's because they need care workers that can provide that intensive care and that, you know, have the right kind of values and skills to be able to stay in someone else's home for that long, etc. So it's a very different model. Then we have self-managed care teams, and these are small autonomous teams that work in a particular neighborhood, and the whole focus is on continuity of care and relationships. They do a lot of values-based recruitment, and they have an outcomes-focused kind of approach to care. So they don't value the time and task at all. It's pretty much the opposite. And then I also looked at the preventative models, and these make use of technology such as predictive analytics, machine learning, kind of digital platform, digital monitoring systems, and they make risk assessments and design the care that plans and predict to prevent more complex care to be required. So they can predict that and kind of see when that's going to happen, and then make changes accordingly. So like hospital admissions and things like that, so they can prevent that sort of thing. So what are the value propositions of each of those that I just mentioned? So the uberisation model is very much around choice, and that's choice both for the recipient and the giver and the care worker. So the platform that I looked at has a bidding system to choose the care workers. So a customer would put in their requirements in the system, for example, and for example, someone looking for care for their mother who has dementia and needs help with meal preparation, perhaps, and is looking for a female care worker who can drive. So the system will then filter the appropriate carers from a database according to these requirements and the level of experience, and they will generate a list of perhaps 25 to 30 carers that are, you know, appropriate for that client. And then a job summary is sent to those carers, and the ones that are interested on that job can bid for it. So they can introduce themselves, tell them why they are suitable for the job, and the client will usually receive maybe 3 to 5 profiles. They can review, they can have a chance to meet or talk. So it's very much that kind of choice in terms of both for the care worker to choose the kind of work they want to do, and also the care recipient to have a few carers, because normally you are given a carer and you don't have a lot of voice to express, you know, if you want it or not. So that's their main value proposition. For the living care model, is a little bit different because all they do is living care. So when I spoke with them, a lot of the home care, they provide all sorts of you know, daycare, living care, respite care, all sorts of different things. And the living care model is pretty much a specialist in just doing living care. And what they do to compensate of these other things is that they have strong partnerships with with other home care organizations, or, for example, if people want some help with funding their care, they would help them with that, but they won't do it directly. So they will have partners. They have a portfolio of different partners that will support people in all sorts of different things when they need care. Then we have the self-managed care teams, and their value proposition is pretty much around trust, community, and outcomes. So they said we build trust in every interaction and applies across the customer groups, family, and the person they support. So they do that by looking after their employees. They provide a salary and not an hourly rate. They provide bespoke training and shadowing a specialist. And so they also provide that trust for the people they support. So they have this initial conversation with them. What is a good day for you? And that differs a lot from the time and task model, where someone would go and do an assessment and say, what can't you do? And then we'll do it for you. And this model is the opposite. What would you like to do? And we're going to make that happen. So it's a very different approach to the outcomes of that person that person wants, rather than just supporting them on what they can't do at the moment. And then we have the preventative model, which is typically used, from what I've seen, in families where they are very, how do you say, so they live in different areas or different countries, different time zones, or something like that, and then they want to have some kind of real-time updates, as they said, to how their loved ones are doing, and that will provide them this you know, this kind of idea of how they are doing, but also to the person receiving care, it can also prevent them into, for example, the functional decline. They will make that compress into later stages. So what they do is they use a lot of connectivity that monitors vital signs or motions or activities within the home. So they know what a typical day will look like, and if things start to go a little bit off that, you know, that normality, then they start to either send a care worker to go and check it out, or give them a ring. So there's a lot of things like that, and they do use things like risk assessments to prevent people from declining further. So that's their value proposition. So this is a very busy slide, just to show you a very summary of different aspects of the business model canvas that's comparing the time and task with the other models, and they are very different in pretty much everything. But what I found the most difference occurs on the customer segment. So on all these new emerging models, their customer segment is not only the recipient, but they also pay attention to their families of those recipients in many ways, and also their care workers. So there's huge focus on the workforce. And there is a lot of emphasis on the partnerships, as I said, with counseling, charities, training providers, monitoring organizations, so it's very much around that. They're much more value-driven rather than cost-driven. Yeah, so those are the main things, although, as you can see, everything is kind of different from a time and task. So what would be the implications for the workforce and the market? So one of the implications to the market is an outcomes-focused approach makes the market more flexible and responsive. So if we are commissioning for outcomes, that enables the providers to use their resources in a more efficient way, and to target them at the times when they, you know, it makes the biggest impact to the individual. So in a time and task approach, there is little flexibility to the care plan. And these emerging models, they offer more flexible arrangements and a more efficient deployment, I think, of the workforce. So the difficulty exists in that the time task is at least is what is being said, that it's easier to standardize and to measure by identifying kind of a unique cost per hour, and the outcomes can be more difficult to standardize and measure. I don't see that as too much of a difficulty, but that might be something that we can discuss. Partnerships enable this holistic care and this enhanced experience. So in these emerging models, these services kind of add value and offer a more holistic care arrangement for the recipients. So in the time and task, partnerships tend to be disincentivized as they are seen as subcontracting. And many times there are elements on their contracts with local authorities that don't allow them to subcontract. So it's a very much control and risk management of accountability. So these emerging models actually take partnerships a much deeper level, which I think is great. In terms of the workforce implications, another one is having care workers as a main kind of stakeholder or customer leads to more opportunities for workforce development. I think it leads to opportunities to better professionalization, better care, and more fulfilled workers. And then for the service users, having those fulfilled care workers also translates into better standards or consistency of care. So, for example, one of the cases they have in terms of turnover, less than 4%, which is a huge difference compared to the 40% average. And they got there by introducing this values-based recruitment, giving their workforce more autonomy, and not making them tick boxes. Very different approach. So I think there's quite a few opportunities for the future. There is a variety of providers. So we have loads of, from small to large organizations, state-funded, private-funded, specialists. We have self-managed teams, matching agencies, all sorts of social enterprise. So I think in terms of variety is great. And there's also a variety of roles: personal care, domestic help, companionship, complex care, reablement, lifestyle support, living care. There's nutrition, hydration, care of the skin. I mean, there's a huge range of roles for care workers as well. And I think there's a huge opportunity for professionalization that offers employers a better standard, a better role demarcation as well. And hopefully that will improve their recognition and their retention. And then for the workers as well, I think if we have that professionalization, we have an increased earning potential, a recognition of their experience, the level of work, also by employers, by society, and by peers, I think is very key. And then also professionalization would increase their career development and growth, and an assurance of affiliation with a recognizable professional body. I think that would be a huge step into professionalizing as well. So just a quick summary of what I just said. So there's this shifting methodology to more personalized choice, well-being, continuity of care, and availability of care in these emerging models. The time and task is obsolete. It's probably been obsolete for many years. And some of these emerging models include the platform model or uberisation, the living care, social enterprises, preventative model, and community-based models. The is the time and task obsolete or just a taboo? I don't know. Probably. So the business model innovation mostly around, as I mentioned, the value proposition, the partnerships, and seeing the care worker as a customer or as a stakeholder in their business. The value-based care system rather than a task-based. Home care and community support becoming increasingly interrelated. But there is hope. I think there's a variety of providers. I think this is a good thing to have a variety of providers. I mean, things a lot of people say that it's too fragmented, but I think it's always going to be a variety of providers and roles and models, and I think that's good. And the workforce development also obviously improves retention, motivation, and performance. And I think that's all for me. Thank you very much.